I say welcome to you. I'm George Grant. I'm the Executive Director for Spiritual Health here in the Woodruff Health Sciences Center. And I'm delighted to have been invited by the Religion and Public Health Collaborative to hold an event in which we have a rich discussion and some engagement around defining spiritual health. We have many experts in the room who are engaged in research and education and service related to spiritual health. And so to have your mass in the room and a collection of your hearts and minds is an important event in and of itself. So for you to be able to sit at each other's table and each other's company and to be enriched by each other's presence is an important moment for the life of the university and for health science. And so tonight, what we have to offer you are some remarks that I'm going to make that is just a sliver of what we might be engaged in when we refer to spiritual health and to foretell the future of what can be with regard to our work life together and for the enterprise of engaging in research and education as we prepare ourselves to meet the needs of the world. In particular, spiritual suffering. So it's no accident that we are meeting here tonight. The WSHCAB, the Woodruff Health Sciences Center Administration Building, brings together under one roof the disparate but related education, service, and investigation of the schools and institutions that are devoted to health in relationship to Emory University. Tonight we step into a knowable and unknowable time and space together. Our hearts and minds may be distracted from the cultural events of the day, and in particular last night. And so if you think your availability is compromised, well, that's okay. Because take heart. You are not alone. Your care-seeking in the midst of any blows to your soul is honored here as a moment to collect and recollect your resources. So welcome. Have more to eat and drink. Our baseline is that spiritual health is impossible to achieve on an empty stomach. It is no accident that a discussion centered on the act of defining the spiritual component of health is in this plaza. Our surroundings lend sacred our local institutions, as you see hanging from the banners, and the mural and figures to my side and behind me invite us to play in the divination of health, meaning in part that we are here to foretell future events. And so I ask you to pay attention to your dreams tonight, for you may catch something unexpectedly that may contribute to this effort. And in the morning, if you can remember those dreams, then write them down and share them with your colleagues as you would as resourcing the effort of spiritual health. Dream work was critical as an intervention in ancient medicine. Active listening and responding holds a direct connection with our work today. From Greek origins of Western medicine to the attempts of Freud to mechanize unconscious properties of the psyche, leading to effective talk therapies of today, we are assembled here. The figures to my left and right, we see Hippocrates to my immediate left. Known as the parent of Western medicine, and really was concerned about standardization and making sure that people held to a common ethic with regard to medicine, is responsible for separating medicine out as a peculiar field and discipline amongst the arts of the day. In particular, to separate from philosophy and religion. But Hippocrates was not altogether successful in that. It would take many thousands of years later for there to be a complete separation of those properties. However, much of what we know today about being ethical in our care responding, we can attribute to the origins of this kind of movement that begins with Hippocrates. Now, Hippocratic principles were directly opposed to any kind of magic and ritual. However, the continuing success throughout antiquity of the cult of Asclepius, who is to my right, shows very clearly that medicine was never fully divorced from its religious connections. Beginning in the 6th century BCE, health resorts or sanctuaries known as Asclepia, because they were presided over by the god Asclepius, sprang up all over the Mediterranean. The cult of Asclepius was at the same time a religion and a system of therapeutics. The sanctuaries of Asclepius, such as those at Trica and those in Kos and Pergamon, were built outside the towns on particularly healthy sites. In these Asclepia, special rites were observed. After purification, preparation, baths, fasting, and sacrificing, the patient would spend the night in the god's precinct or temple, a process known as sleeping in, or as my teenagers would say, a sleepover. It was known as incubatio. Now, the fashion of incubation seems not to have really caught on until the 4th century, when the great healing centers of Kos were established. But we have rational and thaumaturgic medicine, in other words, known as dream therapy, developing together through the Hellenistic period in equal steps with astronomy and astrology. During the night, as the patient slept, Asclepius would appear to the patient in a dream and give that person advice. In the morning, the priest would interpret the dream. The priest and physician were one. Would interpret that dream and explain the god's precepts. Patients would thank Asclepius by tossing gold into the sacred fountain and by hanging votives on the walls of the temple. Now, curiously enough, I wanted to know what these votives consisted of. And whatever the ailment that you had been suffering with, you were to bring back a depiction of that ailment to hang in the temple. And so there was one famous mural of a person who brings back a leg with a gigantic vein going down the side of the leg, meaning this person was suffering from thrombosis of some sort, enlarged veins, right? And so they would hang these votives in the temple as a way of honoring the healing process. Now Galen, who is also to my right, wearing a funny little hat, was, curiously enough, ushered into medicine by having his dream interpreted. He was a philosopher, and by going to one of the Asclepia, he was awakened the next morning, and certainly the attendant there, the therapeutus, was able to say, your dream means that Asclepius wants you to be in medicine. And so Galen became one of the most learned persons of his day and is instrumental in making contributions to anatomy and physiology, pathology, and pharmacology, and his lasting influence for over 1,300 years. He was instrumental in keeping philosophy as essential preparation for medicine and wrote a treatise, The Best Physician is Also a Philosopher. Galen held a deep appreciation for Aristotelianism and the virtue ethics that emphasize the virtues of mind and character. His relationship to the patient as an observer and caring attendant was emblematic of his training to treat the person with sacred worth. Another person who treated persons with sacred worth was Florence Nightingale, who's depicted on the mural on number 17 panel. Florence Nightingale had a very special mission where she would work with women who had been abused and abandoned and who were out on the street and train them to be nurses. Her mission was one of justice, and she was moved from her own source of belief in her mission to make sure that the wounds of people were also attended to in a sacred way. Years after her death, it was discovered that she had collections of thousands of pages of theology that have now been put into books. And one of the favorite pieces that I carry with me about Florence Nightingale is her reference to her understanding of God, who she referred to as the universal spirit of right. I'm always captured by that. Another prominent person on the mural, and I love making use of this space right now, is panel number 22, Charles Drew. Charles Drew was the most prominent African-American physician and surgeon of his day in the early part of the 20th century. He was instrumental in inventing a way of capturing plasma in blood products and being able to store that product for blood transfusions. And so during wartime, blood banks became ways of saving lives. And Charles Drew was instrumental in actually going to Europe and taking charge of the whole blood supply of the European conflict during World War II. But when he found out that the separation of African American blood with persons of other blood was taking place, he quit. He resigned and went back to a prestigious career at Howard University. But his mark on not just justice but of care is often remembered from his religious community of the kind of inspiration that preceded him and induced him to take on the sufferings of the world in that way. I believe that the domain of spiritual health consists of three intersecting fields of concern: research, application, and state of being. Research in spiritual health explores preventative, predictive, and relational elements associated with spiritual well-being, coping, resilience, and other measurable health qualities. In recent years, more attention is being devoted to religious influence and religion's impact on population health from determinants. Those determinants that support health and for those elements that also would impede health. Whole person integrative research includes workings of the inner spiritual experience, as well as physiological changes impacting health, and they are being taken up through measuring practices whose attributes are related to forms of spirituality as well as activities of daily living. Research conducted by and related to spiritual health professionals, such as chaplains, many of whom we've gathered here tonight, is centering on impact and outcome related to spiritual suffering in the inpatient and outpatient healthcare context. The application of spiritual health is associated with relational, ethical, and culturally responsive qualities of delivery in the healthcare continuum. Empathic balance in care responding is at the core of these practice qualities and is personified in and through nursing, medicine, allied health, public health, and spiritual health professions. Increasingly, our work will be interdisciplinary and multidisciplinary as the spiritual health professions share in the work of whole person health through particular functions with sister disciplines. Spiritual health as a state of being is a composite initiative defined as institutionally and individually equal to and interactive with physical health states and mental health states contributing to overall human health. In a brilliant article I recently came across by Komatra Chung Seshin Sup on the workings of spiritual life and health impact assessment, I have been introduced to the efforts of whole person health in Thailand. I was moved by the freedom of the author's use of Western philosophy and scientific method to propose an approach to assessment that includes spiritual life and health as equal determinant to health among the existing knowable biomedical and psychosocial models. Dimensions of health beyond material and biological phenomenon have been sidelined, but perhaps waiting in the wings to re-enter as whole person and ecological systems to challenge the relegation of body to mere function. To take seriously that health is not merely the absence of disease, then it is ours to cope with the existence, and it requires attention to a meaningful life. Intentional growth that comes from embracing changes toward optimal fulfillment. These saliently and spiritually laden features, referred by me and my colleagues in a paper on workings of the human spirit, are not easily captured, but more fully understood as fluid relationships, no less impactful or real than the more easily measured and known physiologies. In our small group, led by Linda Emanuel, a palliative physician and psychoanalyst, we postulate a permeable existence of spiritual essence, physical states, and psychosocial narratives within and always surrounded by a greater existence. Access to the spiritual cosmology of greater existence, for some of us this is God, can be direct from the spiritual essence of persons or groups and marked as sacred moments. These can be fleeting or prolonged experiences of holiness in more traditional religious experience, or in ordinary and extraordinary life events. In this model of measuring and understanding the care response to spiritual suffering, we are working with estimating what happens when equilibrium, the balance of life, is disturbed and even assaulted. A kind of perturbation that sends our world into question and even deep pain. A response that is depthful and respectful may lead to 4 interactive processes that can be the fabric of connections for the social, physical, psychological, and spiritual. One process may be a discovery phase in which questioning and knowledge elicits another process of dialogue, which allows for a person or groups to safely explore toward a process of struggle. The struggle, in turn, may lead to movement toward arrival or further distress and connection. To be available to the assault and to the processes that unfold is about the workings of the human spirit, which wants integration and connection. Chung Se-Shun Sup channels William James's words from his seminal work, The Varieties of Religious Experience. In the pursuit of what constitutes an estimation of spiritual health through immediate luminosity, philosophical reason, and moral helpfulness as tested by the value of their fruit. However, spiritual health resists definition because of its subjective and relational state. To know the unknowable is the greatest challenge in bridging scientific method with such a vast and infinite experience. However, I pose a question. Can we discover, rediscover, explore, and examine the fruits of intentional growth and the elements of environment in time and space enough to contribute to a greater understanding of overall health impact? I vote yes. My new Thai friend has proposed factors and changes that can be assessed and measured toward this end. The factors enhancing spiritual life may include the knowledge of texts, myths, folklore, rituals, metaphors, all those things that embody essence, along with structures of temples, mosques, and churches, spiritual leaders, associational life, networks, and communities of practice. The actors of time and space with rites, ceremonies, life cycles, calendars, sacred spaces, gathering sites, and significant architecture are all a partial set of conditions that support the spiritual life toward health. The workings of this human spirit exist in a permeable atmosphere that is fluid in relationship to greater existence, the universal spirit of right. And they can be assessed through an exploration of the conducive environment toward spiritual health. This environment would include adequate basic physiological needs, balanced and expanded gender roles, a multi-generational society, community cohesiveness, optimal life tempo, and sharing and cross-fertilization in cultural heritage. What we termed as a crisis or assault to spiritual health in the workings paper, our Thai friend outlines the more general detriments toward this estimated spiritual health. These detriments are disenchantment with life and nature, the masculinization of thought, meaning emphasis on objectivity as opposed to relationality and empathy, a decrease in cultural diversity, extreme materialism, and consumerism, all artifacts of value systems that vary from culture to culture, but are nevertheless universally impactful. The quintessential statement of Dr. Ellen Idler's important volume, religion as a social determinant of public health, is that the primary determinants of health around the world are not health services and medical care, but the conditions in which people live their daily lives. Spiritual health professionals, or as I now refer to us as SHIPs, are clinicians, educators, and researchers who are now called to be in and beyond traditional health roles. Exposing ourselves to the conditions of the human spirit through assessment, measurement, and care response is the imperative. To meld the values of meaningful life with biomedical and psychosocial estimations will be the kind of bridging enterprise that is becoming the discipline of spiritual health. I believe that the human spirit is composed of the consolidated energy that collects and recollects resources necessary to flourish, or at least cope with the complexity of earth life. The human spirit desires and seeks out connection. To this end, we are incorporating many initiatives to respond to the need, one of which is a new collaboration with Community Health Ministries. And this is led by a specialty director, nurse leader, Rebecca Heitkamp. She's seated right over here. Wave. We are working with Rebecca to certify nurses and others to embed themselves in their own communities and to listen and to respond to the basic and meaningful desires of persons seeking health. We are concurrently embarking on a new research ship to which we are appointing a director of research in spiritual health. Chuck Raison is a physician psychiatrist who will soon join our team and lead us in conducting studies that attend to these desires of the human spirit. He is published in Compassion Meditation, which enables us to join hands in deep relationship to our partners in the Emory-Tibet Partnership. Our Director of Education, Maureen Shelton, seated right over there, wave. She will speak to this connection work in a little bit, but let me add that Maureen, within a month's time, will be a certified teacher in cognitively based compassion training, to which we are all proud. Our research effort has also produced a gift when one of our own fellows, who recently was awarded the resources necessary to study epidemiology at the Rollins School of Public Health, and has also already been producing fine work in her first semester, is here tonight. And I've invited Kim Palmer to introduce her working model of human spirituality that I think is conducive to our discussion of impactful human connection. Following Kim presenting her model, Maureen will also bring to us some thoughts about CBCT, and then we will have some question and answer and open discussion. Thank you for listening. Yeah.
Good evening. Many thanks to George and to everybody for being here. I'm delighted to be a part of this. So I wanted to share with you a little bit of the information that I have regarding some of the research that I've done as a preliminary effort in my schooling. And this ties into what George was talking about in terms of the aspects of spiritual care in a healthcare setting, including those elements of research, application, and state of being. And I'd like to think that this touches on each of those areas. Researchers in religion and spirituality and health have noted that there's a need for grounding research more fully in theoretical models, and also on the need for agreement on definitions of religion and spirituality, and also clarification on how to operationalize measures for those constructs. Looking back over a great body of research on religion and health, It's clear that most, especially the early research, has been developed with Christian populations, or at least monotheistic religions, and that the measures have been largely focused on those groups. And the measures have also historically been limited to fairly simple measures of religiosity, and those primarily have included attendance at worship services as something concrete to measure, and sort of a stand-in for, or a proxy measure for how religious somebody is. Then more recently, we've seen an increasing trend to see spirituality as a universal dimension of human living. This is especially relevant with the growth of the religiously unaffiliated population. 23% of U.S. adults are now religiously unaffiliated, according to the most recent Pew survey. To respond to these changes, I believe we need to have definitions broad enough to include people who are both religious and not, theistic and not, and that we need a theoretical model that can conceptualize people's experiences, ground future research, and help guide us in a selection of measures. So I'll begin by sort of explaining that religion and spirituality are interrelated but separate constructs. I think there's increasing consensus building that religion is characterized by the formal, structured beliefs, rituals, and practices of a specific faith tradition. And spirituality, being a bit broader, is that dimension of human living that relates to the search for and expression of meaning and purpose, connection to self, others, the transcendent nature, and the experience of inner peace or harmony. So my premise is that we need to develop models and measures that will capture this experience of a wider diversity of religion and spirituality and perspectives of a wide variety of people, and then to tie those in to the mechanisms by which they impact health. To that end, I developed my integrated model of religion, spirituality, and health. And I've passed out a copy of that for everybody. I hope everybody has a copy. And this is intended to be suitable for both religious and non-religious persons, those who believe in God and those who do not. And the consideration of both positive and negative religious coping, which may either enhance or inhibit good health outcomes. Also, I'm looking for the model to help with the exploration of the mechanisms by which health is impacted and to serve as a guide to point researchers toward what measures might be suitable for specific research interests. So if I can, I'll just take a few minutes and sort of describe what's in the model. You can see there's sort of 3 central overlapping circles surrounded by 2 outer rings. And if we begin with that innermost area, those 3 circles represent the 3 dimensions of spirituality, of meaning, connection, and inner peace. So within the dimension of meaning, we might find things like existential questions, questions about what our purpose is, issues of ultimate concern, issues relating to our beliefs and values, and what constitutes for us the sacred or holy. Within the realm of connection, we can locate the human yearning for and the sense of being part of something larger. And that's through connection. That might be connection to our families, our communities, or faith communities, humanity, or all of life. Or through connection to the natural world, the universe, or a greater force or energy, such as God, spirit, or higher power. And then the inner peace dimension encompasses a sense of acceptance, the ability to integrate life events such as illness or death, and to achieve a sense of calm or harmony or balance. And I like to think of inner peace as being sort of characteristic of spiritual health as well as sort of a dimension. And although these dimensions overlap and interact in multiple ways, I think meaning and connection often overlap with inner peace in a way that reflects directionality. So I'll talk a little bit in a minute about an example that might illustrate that. But when I move now to the first outer ring that surrounds those dimensions of spirituality, those are the facets of religion that relate to those spiritual dimensions. And those might include, within each particular faith tradition, the teachings or rituals or practices or worship or fellowship services or the philosophical underpinnings that people carry with them as part of their religious life. And then the very outermost ring represents the mechanisms that mediate the association between spirituality and religion and health. And those include social support, which might affect the spiritual experience of connection, whether inside or apart from a religious community. The physiological stress response, which is influenced also and influences a sense of inner peace. And health or lifestyle behaviors, which might include both prescriptions against certain behavior by a faith tradition and also by one's understanding of self-worth and the sense of how the person is to interact in the world. And although I don't have it depicted in the model, just because there was not enough space on the page, each area of overlap among the dimensions of spirituality or between spirituality and religion can influence health both in positive and in negative ways. And to give an example of that, I'll kind of situate within the model what we might find in the interaction between religion, meaning, and peace. Say for a Jehovah's Witness patient who is declining what's deemed to be a medically necessary blood transfusion. So this might have a deleterious effect on their health, might even lead to death. But it also may lead to a great inner peace resulting from coherence of living out their faith values, a sense that they are adhering to God's will, perhaps a sense of taking comfort that they're assured of salvation and an afterlife. So that inner peace might, at least in part, help counterbalance the negative health effects from refusing a blood transfusion as the stress response is calmed and a sense of inner peace or harmony is achieved. The spiritual dimension of connection, in a similar way, can also exhibit a positive or negative effect through the mediating mechanism of social support. So a person who feels isolated, either from their community or abandoned by God, may have increased stress and reduced inner peace. That often leads to poorer health outcomes. While a person who perceives a great social support from family, community, or God may feel a greater sense of peace. And one of the ways I think of in using the model is to kind of think about what a patient's experience is or what a group of people's experience is within that set of concepts and think about how that might help a researcher. So I'll take as an example a researcher who might be interested in the intersection of spirituality and health among those who are religiously unaffiliated and non-theistic. So we might want to know what factors are included in what these folks consider to be sacred or what's of ultimate worth. You know, and where do they find their deepest connections? What in their worldview helps them make meaning of their illness and what helps them cope with it effectively? Are their beliefs contributing to positive coping or negative coping? So there's some measures that might be helpful for that. Those might be things on taking measures on purpose, a sense of purpose in life, or existential well-being, measures of social support, measures of spiritual peace. All of these things might help illuminate their spiritual resources and help tease out the effects that they might have on health. So that's just sort of a brief overview of the model that I have developed with a sense of spirituality that's universal and from which, you know, from a clinician's point of view, I can situate the patients that I run into, even though they vary widely, all within this model, and help guide not only understanding of the spiritual interaction of the caregiver, but also perhaps help point the way of what kind of research might be helpful. Thank you.
Good evening. It's good to be with you. I think this is just for recording purpose. Can you hear me okay? Okay, great. So again, I'm Maureen Jency Shelton, and I direct the education program for spiritual health at Emory Healthcare, and it's wonderful to be with you this evening. I just wanted to add another layer and want to provide some time for conversation as well, because there's been so many wonderful concepts introduced here and thickened out for us. But wanted to let you all know and just explore with you the role of clinical pastoral education as a part of the spiritual health program. That is a movement that is accredited by the Association for Clinical Pastoral Education, which is accredited by the Department of Education, and is very integral into continuing to integrate education and research into spiritual health. And a core aspect of CPE is connections. Looking at our inner connections, our inner world, developing knowledge of that, developing more knowledge of how we're connected to others with best practice, and how we look at the outer systems we're engaging in. And that's a concept from Daniel Goleman, who looks at emotional intelligence. So one of the ways that we do that inner, other, outer awareness is through action, reflection, and action. We have different paradigms that we use, such as the verbatim, where folks come and they present cases to a peer group and to a supervisor, where they write out as much as they can remember of a conversation and reflect on it psychosocially, theologically, and integrate their own aspects of their life that they bring to that encounter, and then ask for consultation. So we are continually looking at that action and reflection and action process to not only maintain our best practice as spiritual health practitioners, but also to do good self-care. And one of the pieces, as George was mentioning earlier, that we're adding to the tools that we have for this to help with this map that we're developing in spiritual health is the cognitive-based compassion training. And I want to mention Sherry is also another one of the people who's almost finished with her teacher certification, if you're not already. It's wonderful. And she's joined us at Midtown as an intern. It's great to have you here with us. And most of all of our residents, I think all of our residents and our SEFs, our supervisory education fellows, and our staff and faculty have been trained in that this year. This is a wonderful gift that we've been given in our partnership with the Emory-Tibet Partnership. And this is another tool for our map, because this modality has 6 modules that helps us get into more in depth some of this action, reflection, action process. Again, looking at the inner, other, and the outer connections. And let me just read you through some of these modules that we explore just to give you an idea. Developing attentional stability and clarity, insight into our mental experience, self-compassion, cultivating impartiality, appreciation and affection for others, and empathy and engaged compassion. So as we're about this work of going into people's suffering story, this is crucial for us to maintain an awareness of how we continue to look at our mental experience, our inner experience, and how to keep aware of what we might be projecting onto other people, what we might be imposing onto other people, so that we can clear that away through these tools and these practices as much as possible, although we can never do that fully. That's why we have the action, reflection, action process over and over again. But to do that with as much intentionality as possible so that we can be really available to the other's suffering story. So I just wanted to let you know about some of that integration that we're doing into our ongoing action, reflection, action process with CBCT, because we really believe in the parallel process of what we do in the group room when we present our verbatims in our cases and how we interact together as a group in that space really develops skills that we can bring to the patients and families and the staff that we work with over and over again. So thank you for hearing a quick summary of our education program, and we look forward to developing this further.
We may have time now, just for a few minutes, for any kind of comment or question, please. you get recorded.
All right. I am from the School of Medicine, working at Emory for 45 years. I am pathologist and also an obstetrician and gynecologist. I am also a Hindu priest. This goes to show why I am here. And I'm very happy I'm here, because all the discussions, they lead you somewhere, provided you are ready to be led. Otherwise, you can go exactly how you were when you came here. You don't want that one. For example, let us look at this mural and learn a few things. Say number 10. Number 10. The physician is examining a boy. The boy is looking in one direction. The physician is looking in another direction. Instead of that, he's a boy. Put your one hand on his head, on his shoulder, and say, I'm going to examine you with this, what is called stethoscope at that time. So there is a dissociation between the patient and the doctor. One fundamental problem. Then let us go to number 21. That is a pathologist. That's what I did most of my life. And I can see he is by himself in 21, picture 21, there is no man there. There is no soul there. He's just looking down the microscope. He is completely detached from everyone. And that's what we call an objective evidence. It's not. It is a lack of subjectivity which we all need. Similarly, if you see all the pictures, in 22, he is looking at the patient who is almost passing out, but he doesn't care either for the patient because the doctor's eyes are not on the patient, and his mother standing next door is completely neglected. This is where I believe the religion comes in the picture. It induces in the patient a confidence to listen to the patient with a spiritual aim. It induces a spirit in the doctor not to be so detached that you cannot even identify with the patient. And number 3, all of us at some time will have to be spiritually oriented. And what is this spirituality? I mean, I have dissected as a pathologist so many bodies, never saw anything like a soul in the human body. There is not even a cavity where I say, this is where perhaps the soul of the patient, the disease lies. No. So basically, the spirit is the connection between what we feel here and the cyberspace above. It does not need any space. It does not need any cavity. And that is what we are talking about. And being from India, there's a nice Sanskrit word, mangalam. Mangalam is something which you use when you are bodily, psychologically, and spiritually healthy. And that's we want our patients to be. And for that, first, we have to be like that. Thank you.
Oh, wow. Woo. I feel my heart strangely warmed. Any other final comments? I want to thank everyone for participating tonight. I wish we had more time because we could have some rich discussions about what has been remarked upon and introduced. But I ask that you take it upon yourself to take in bits and pieces of what you've heard and assimilate to this discussion and get back with us. Get back with us in the Religion and Public Health Collaborative with Spiritual Health, your colleagues where you are, and let's continue to move toward defining of spiritual health, that which we will never get there, but we're on the road. Thank you so much. Blessings on you.